obviously like to thank Jennifer for showing us the roadmap, I guess where we need to be going to, and it's certainly interesting some of the things in relation to the residential care and the whole community side, because I think with the Sláinte care and the shift left into the community, there's a lot more desire to get better costing, better systems for the community. We know there's not as good a systems in the community as there are in their hospitals, but we have to start somewhere. So maybe I'll kick off with my presentation now, which is really just, I suppose, just covering the implementation plan itself. I also want to just, maybe Stephen touched on it earlier, it's notwithstanding that we haven't been able to use ABF for funding. And I think it was interesting to see what was happening in other jurisdictions. Work has been going on in relation to, I suppose, actions within the implementation plan. So it is an implementation plan 21 to 23. Some of the other speakers today, Fiacre and Brian and Jackie, will touch on some of these actions as well in their presentations. So I won't repeat them. So, just I'll cover some of the scope of ABF in hospital systems and maybe why Sláinte Care is asking us to go into the outpatients and ED. Just the role of the healthcare pricing office for people who are new. I'm conscious that since the last conference we certainly would have had a turnover of staff in the whole in the hospital areas, and indeed in the coding and costing field. ABF, how it operated in the pandemic, why we're actually doing the ABF, where it's coming from, and the implementation plan itself, and then at the end just the next steps, which I think is the key piece going forward. Okay. Briefly run through this. We've probably covered this in other slides around our population, how many, we 43 hospitals at present in ABF. Sláinte Care is asking us to move to bring in all hospitals. The admitted care area is the 1.7 million that's been dealt with, and again the ED and outpatients is outside at present. That's our 1.67 million episodes. Again, the reason why we do ABF is so not all of those individual DRGs are treated as one case because of the complexity and cost of the different patient types. So if we didn't have HYPE, if we didn't have DRGs, all those cases will be treated as one case, when clearly the resource usage is very variable. So as our current scope for ABF is admitted care, day case and inpatients. Everything else goes through the block, which includes outpatients, ED. Other is a funny. It relates to I guess services provided in the acute hospital system that doesn't relate to the activity of the hospital. So services provided by labs, radiology for community, for GPs, they're all in the cost base of the acute hospitals, but we have to separate that out in the costing process. And that's just some spend to give it some context. I know we're going back to 2019, which again is the last year not impacted by COVID. So the ABF accounts for roughly 68% of the total acute spend. That acute spend has certainly gone up in the intervening period, but obviously is contaminated with COVID costs. So it's difficult to get the handle on costs that Joanne has mentioned. So what do we do in the HPO? Pretty much we do the funding, so obviously the pricing for the funding, we do costing, so we train the costing teams and review the costings, carry out costing audits, the same with the coding, we train the coders, the whole data validation, data quality, we have a data analytics section, we do audit, training and education, we do monthly reporting of ABF, which again I think it was in Mike's talk where he was basically talking about, the ability to compare data by consultants. So that facility is there actually within the ABF reporting. We do go down to consultant level at the DRG level. So again, a lot of data there. It's a matter of how we use it. We also answer PQs, freedom of information requests, and monthly reporting against the service plan. This is clicking. Sorry. Yeah. So what is ABF? I mean, I think we're all pretty clear on this. We're funding patients, not institutions. So activities driving funding, not history. And when we do carry out ABF, essentially hospitals are contracted to carry out an agreed level of activity specified at the DRG level. It's also profiled monthly to allow us report against it on a monthly basis. Underlying assumptions about ABF, and again, this is going back to the idea that we need to assign a complexity to each case so that the diagnosis and procedures validly describe the care, that the groups are clinically coherent, complexity is validly captured, and that's the importance of coding. So I think in Mike's presentation this morning, he was very clear around the importance of good documentation, because the coders can't code it if it's not there. So if it's not in the chart, it didn't happen from a coding perspective. Also important, the cost is captured, the cost is properly assigned, and there's comparability across the health system. I think this idea of comparability is a key piece. Even if we didn't fund on it, just the ability to compare. Now, that's what Jerry has mentioned around the ED, that having consistent collection systems that are comparable makes that comparison doable. ABF, what it's not about is obviously increasing the level of funding available. It's not an unlimited source of funding. We do get our budget determined by the Department of Health, ultimately Department of Finance, where Stephen's gone off today. So, and it's not a panacea for all hills in the health system. I think we have to be careful about expectation. So just the process itself, we set the prices using the cost and activity data, but the minister sets the global hospital budget and national service targets. So that's the piece around, the budget that we get assigned to us. It's not unlimited. It's allocated at the start of the year, but also the HSE's contract with the department is the national service plan, which does set out activity targets. And that has been a challenge for us in the COVID environment, when we've, a bit like Joanna said, when activity targets have dropped so much, what is the appropriate level of activity for the following year, and what are the assumptions around that in relation to COVID and how COVID will be there. Some goals of ABF, I think this is pretty much again seen in Joanne's: increased transparency, comparison, also using the data set for broader use. I think that's got to be a key piece. I think if it's one thing that COVID has taught us, is that data has become important, and good quality data. So I think that it's never just for one use. I think when you use it for ABF and there is funding on it, the quality tends to improve. And I think that's certainly what we see internationally as well. But it's just the idea that it's not all about the funding. It is about having that information available. And indeed, in other countries now, we're seeing a move to calling it activity-based management, not funding, because really it is a management tool. Won't go through this. Most people will be familiar. Obviously, we use the hype data. We use costing especially costing in PLC, and then Fiacre does his magic and puts it all together to set the prices. And Fiacre will present on that this afternoon, on the pricing framework and the price list. This is just a slide, I suppose, to give some idea of the kind of risk profile of the various reimbursement systems. And I think it's kind of interesting to see, well, why would you use DRG from a risk perspective? Where does the risk sit? So I think if we have a fee for service, then the incentive is to overtreat. If you have a capitation system, then the potential is to undertreat. So essentially DRGs are in the middle, where the risk is essentially shared between the hospital and the provider, and the funder, sorry. So what does ABF facilitate? It allows us that ability to compare and analyse, and we do that in relation to our monthly reporting, where each hospital gets an activity target at the start of the year, and that has happened notwithstanding we didn't use it for funding. And Lorna does a lot of work in relation to using that or updating that monthly file, which has been driven by the monthly returns and the hype data. So I guess the importance of that monthly reporting is to have timely data. So the importance of getting your data, coded data in on time, will be a key critical thing for us going forward, just that we to ensure that our reporting makes sense. So that's available, and we've about 300 users at the moment. Review performance, so again, it's part of the monthly performance meetings, and the Maureen Lynn herself does the monthly report on the ABF reporting that goes to those meetings. And as I say, it's work with better, more reliable data. So As I say, I think that piece, I can't emphasize it enough, the importance of, getting that data, getting it timely and good quality data, because it's the number of uses that it has outside of just ABF. So just a few slides. Stephen touched on this morning, just around how ABF operated in the pandemic. Cover these main points. I mean, obviously, we dropped about 200,000 cases year on year between 19 and 20. So clearly, ABF isn't appropriate to fund in that environment. Joanna's explained what they did in Australia, but notwithstanding that, we were important that we still carried out the process. So we still collected our costs, we still collected our activity, because it's important that we know the impact of the COVID, and Firka will cover some of that in his presentation. So, as I say, internationally, most ABF countries would have reverted to a block-funded system. There were different ways of doing that. They paid for activity that didn't take place. I think Germany paid for unoccupied beds, but basically it was really feeding back to a fixed block-funded situation. It was important for us to ensure that even though we weren't funding on it, the process is maintained. So the data was being collected, we still got the costs, and that the process will be in place then when ABF, goes back to normal post-pandemic. So just some of the things we did then in relation to, and Stephen would have mentioned some of these, we still had to come up with an activity target for the National Service Plan, and Emer did a lot of work in that with acute hospitals in relation to what is an appropriate activity level for 2022. So it goes back to Joanne, you have to come up with assumptions, and 2019 height data, that was the last year unaffected by COVID, was used as a base. And then we looked at 3 months in 2021 where there was least impacted by COVID to get a sense of what's the most recent data set to be projected forward for 2022. So that was a various process. We were still able to do that because we had hype data. We had hype data for July, August, September in 2021, so people were still returning the data, so we were able to use that data. So that's how the plan was put together. There was assumptions made around emergency activity, and that would increase in 2022 vis-a-vis 19, and that's how the plan was put together. So we also have to be mindful that the plan has to go back down to hospital group level for the group operational plans, and down to hospital level, and then profiled monthly. So it's quite a piece of work that had to be done, but again, we were able to do that by having the data that was returned to us as part of the ABF process. Funding requests for new services, for new beds, we would have used our costings for, depending on the type of bed, whether it was a normal acute bed or an ICU bed, and whether it was a fully absorbed cost we needed to apply or a marginal cost. So again, we were able to take that from the costing. The need for data, I mentioned this already, just that the whole COVID, what COVID has certainly brought out is the importance of data within the decision-making process. So we would have returned data daily to the COVID data lake, but before we could do that, we had to bring in codes for COVID to capture the COVID data separately. We then had a coding system of within 48 hours, and I'm sure Jackie will cover that in her presentation. But the data used from the hype allowed us to give good data in relation, particularly ICU, in relation to the type of patient who was going into ICU, in relation to age, sex, length of stay, diagnosis, where they were coming from, referral source and discharge source. So certainly we got a lot of information there around the type of patient and the lengths of stay within ICU. So again, that's another reason for, to keep the coded data up to speed. We were heavily involved in the private hospital arrangements, which, again, we took the hospitals over initially for the first 3 months for Safety Net 1, and we would have used our costing data to benchmark the information coming from the private hospitals. Obviously, there's different conflators between public and private. We don't have interest in capital, they do. We've probably more training. But still, it was great to have that benchmark to see, are we on the pitch or is it crazy? So again, we would have used our data for transition periods after the Safety Net 1 finished. Safety Net 2 then, we learned from Safety Net 1, we didn't take over the hospitals again. So we operated in a fee-for-service, but within that fee-for-service, we were looking for guaranteed capacity, so we had to pay a retainer for unutilized capacity. And again, that was on a cost per bed day, and we would have used our costings to compare that. Safety Net 3 was brought in for cyber attack. Safety Net 4 is now in place and due to finish today, but my understanding is it's been extended for non-waiting list activity. And for the waiting list activity, Brian McCarthy and his team in IT have been very busy in developing a payment platform for the purchase of waiting lists from waiting list procedures, and Brian will present on that in the afternoon. But essentially, we would have had VHI administering the payment system for us in Safety Net 4 and 3, but for waiting list activity post 30th of June, so from the 1st of July tomorrow, waiting list activity will be either sourced in the private hospitals through NTPF or through the HSE payment platform. The procurement framework, this is the process which has the procurement process to allow that waiting list piece. Again, Fiacre and his team would have taken the entire waiting list, excluded NTPF activity because we didn't want to be tendering against NTPF, and would have also mapped the activity from procedures to DRG to come up with a DRG price to benchmark against the ultimate tender prices. So again, that's an extensive piece of work that really facilitated that procurement framework that was carried out last October, which is forming the basis of the waiting list payment process. Best practice tariffs continued, notwithstanding we weren't funding an ABF, and in fact increased in 2020 over 2019. So that was just basically showing that other activities were happening on the non-elective side. Basically, €1,000 is paid. We're an agreed care pathway. So there's about 7 different standards that are used, and if they're met, then a best practice tariff is applied. So NOCA administer that, but our IT team provide the backup information to support that in the context of a HIPE portal. So anything. This is the wrong place. Consideration of quality factors. I think we've dealt with this on the hacks. So suffice to say, we were looking at what was going on in Australia, and we actually have one of Joanne's colleagues working with us on that, Paul Lynn from Australia. So he's been with us doing this work, and Fiacre and Jackie Curley put a lot of time into this. Again, to say, Australia's shown us the roadmap. Quality is always an issue around payment systems, and I think where you have good systems in place to collect data. Now, we have issues over the quality of the data at the moment, and we're working through those, but I think it's certainly an area that we've been working closely with Mike and QPS on this matter. In relation to unavoidable readmissions, an individual health identifier will help us in that. We don't have that at the moment, but I know it's there for the vaccination program, and we're trying to. Hopefully, something will come out that will assist us in that. Because I think, just as a rule, I think even in the HIPE data, if we had an IHI, being able to track patients across hospitals, I think would be fantastic, and a lot more, use of the information we have. Other ongoing ABF work, as I've put these separate presentations, with ED pilot, which Jerry has mentioned. Lauren has gone through the outpatient. Fiacre will talk on the pricing framework, which gives a broad overview of all aspects of the process and establishes a new annual consultation process with effect from 2023. So again, that's something that we're mindful of our colleagues in IPA around the whole transparency piece and that engagement piece. Mark and his costing team have completed a costing improvement plan and creation of a HPO costing webpage, which is a central source of information on costing in ABF, and Mary will present on that in the afternoon. Ongoing training and education has been ongoing, including coding exams. So notwithstanding the lockdown, we did manage to get exams taking place. So Marie and her team and Deirdre would have been heavily involved in that. The HIPE governance group continued quarterly meetings. Coding, training and education still continued online. Obviously, we weren't able to manage or do our costing or coding audits because we obviously couldn't get out to the hospitals. And I suppose that's certainly, one of the areas we're trying to get back up and running, if you say back to normality, that we can start getting back out to the hospitals to carry out our audits, but also to as part of our stakeholder engagement and to training and education wise, just to get at that, because that is a big part of the plan. Is that whole stakeholder engagement piece, and we developed a separate stakeholder engagement plan as part of the implementation plan. So, and I think just while I'm on that topic, we have a kind of questionnaire around, online questionnaire, where we're asking you to identify if there's areas you need training and education on in your hospital, to contact us so we can get a feel for what's the type of training and education you need, and who are the people that need it. So I would ask you to look at that and get back to us. National and international reporting continued, so PQ's FOI requests, OECD reporting, System of Health Accounts, EU directive on cross-border treatments. I see Catherine is there. So obviously we had to keep updating our price list each year to ensure that the EU directive on cross-border treatments, so that we pay the same price for anybody getting treated up the north or in Europe as we would pay in Ireland, so up to that amount. So it's important that, again, that was another reason for us to have consistency and stability in the pricing year on year. So we couldn't allow the kind of impact of COVID on the prices to which would have been a 20% increase year on year. So Faircare will go into that in more detail. So just ABF as a priority. So this was obviously coming from Sláintecare. This is what Sláintecare was asking us to do. Expand ABF for inpatients and day cases to other acute hospitals. So that's the 43 to the 48. Significantly increase the proportion of funding, so by reducing transition adjustments. So we have a transition adjustment as part of the ABF funding. Examine the use of ABF for outpatient services, so that's hence our outpatients and ED, and advanced community-based costing program to measure unit costs in the community. So we've been tasked with costing service to commence the costing in the community. Community is such a wide area, and we're really just doing a scoping exercise at the moment, and Mary is heavily involved in that, when she'll present on that. So that's what Sláintecare is asking us. Paul Reid mentioned just about the fact that ABF was a priority in the corporate plan, so under financial control. So again, it's there in the corporate plan. The implementation plan itself, I suppose the first implementation plan laid the groundwork with the HPO being established, patient level costing being developed. The second plan then is really moving on from that, and as I say, we certainly have been delayed due to the impact of COVID, and I know Mike is gone, so he's well aware of our challenges on that. I would just like to thank Jennifer Nobbs, is in the audience. Jennifer has done a lot of work and was of great assistance to us in putting this implementation plan together. Jennifer has come from the Independent Hospital Pricing Authority herself. So she was instrumental in getting this plan finalised, and also, again, taking her experience from what was done in Australia. And I think that's where, it's great not to be reinventing the wheel, because, we're going to people who've tried and tested, and I suppose what we're trying to do is learn from their mistakes, or if you were doing it again, what would you do differently? So the implementation plan itself, reaffirming government's commitment to Sláintecare. The plan signals a shift in accountability from ABF, for ABF from the HPO to the whole system. So clearly, HPO can't deliver on ABF. It really is the responsibility of all the stakeholders, and I think that's the message for today and in the plan itself, and that's why we've put a big store on stakeholder engagement. The plan sets out a series of 35 actions which will enable the ongoing implementation and expansion of the plan, and they're highlighted in the plan. So I've mentioned that shift in accountability, and I think that final piece just about the ABF data and insights can be used for everyday planning and decision making. I think Mike put this up already today, the mission statement. That's obviously contained in the plan. It's evidence-informed system of healthcare resourcing that drives transparency, equity and efficiency. And look, these are the same, you see the same around ABF, any funding systems internationally. It's always that piece around transparency, fairness, efficiency, promote stakeholder cooperation, and that greater use of quality health data. And I think that's the piece that, you know, I keep going back to that. You know, we see how much the data has been used, and that's why I think where we put a lot of store, Fiacre and his team on the data analytics, and Jackie and her team on the data quality in kind of reviewing the data to ensure that, you know, it is accurate, it isn't, you know, either undercoded or overcoded, but that, you know, again, it's an accurate reflection of what's happening. To improve the health status of service users by combining accurate cost measurement with systematic measure of outcomes. And I think, look, that's coming through everywhere. The quality piece is coming in, and how do we link outcomes to payments? So it's always a challenge. There's a number of operating principles within the plan, and again, you know, this would have been working closely with the Australians around engagement. So again, I've mentioned the stakeholder consultation. And that's, again, you know, Fiacre's will cover that in the pricing framework around, you know, that we're trying to get people to feedback in if there are issues that we need to be, you know, to know what they are and how can we work through them. We would like, obviously, you know, if there are issues that that can be backed up by data, rather than saying, oh, you know, the DRG is crap, or it doesn't, you know, it needs to be more than that we can actually take something away, investigate it. We do have a HYPE governance group and a technical team behind that, and we also have on the costing side, we've got a lot of you know, good people on the costing side who can investigate costing issues. Responsiveness is a key piece as well, and I think we have to be able to move in relation to changes. We know that there's going to be, you know, the RHAs coming in, so we have to respond to that. Independence, again, is coming from Australia, that was you know, separate from the state. We are, I suppose, our price setting function sits in the department or in the finance division, which is obviously separate from acute hospitals. Support integrated care in the appropriate setting. I mean, that's clearly as well signs, you know, around supporting making sure, I suppose, that the incentivization is to provide care in the most appropriate setting. I think that's where we have to be careful about incentives between the different types of care, particularly as we move into outpatients and ED and out into the community. Support health service design, I've mentioned that in relation to the RHAs, and feasibility. So I think that's always that, you know, you don't bring in something without doing pilots. So you have to try things out and get a stable implementation based on pilot projects and testing. So you can see that's what we're doing in the ED and the outpatient space. So just what the plan covers is so basically embedding and further developing ABF. So I've mentioned the transition adjustments, expand ABF, we've mentioned that. The third piece I think is important, and Stephen touched on this morning around having hospital-led implementation plans. So I think hospitals need to start looking at what are their requirements around ABF in relation to ensuring that there's sufficient costing and coding resources, because it is key. I keep mentioning about the coding coming in on time. It has given us a lot of challenges in the last year around, you know, like obviously we've had a cyber attack, so, you know, we have to take that into account. But I think it's given us time to, you know, for hospitals to put a plan in place to ensure that, you know, it is sufficiently resourced. And I think Stephen has mentioned the funding aspect of that as well. They publish the price list annually, consult annually. That's what Fiacre's presentation will cover. I think the price list is there and it's out in the reception area. And so that's, again, one of our requirements, and new classification systems for ED and outpatients, which we've touched on already. Improving data and data collection. So again, continued improving and supporting of the HYPE and costing. And that would mean a lot of engaging by us. I know our costing team currently do a lot of engagement with the hospitals around the costing, including bringing in new hospitals into patient level costing. And I think the patient level costing is certainly an area we'd like to start driving, because it is challenging. It's a difficult area, but certainly we feel it's you know, essential as we move from this activity-based funding to management, that you're able to put accurate costs against the activity. Build stakeholder understanding and support for the value of good quality timely ABF data. That's the piece I've mentioned earlier around, you know, us engaging with the system. And we fully understand that it's difficult for clinicians to take time to attend these conferences. So I think we're certainly keen that we will attend the hospitals and have the appropriate training there. Improve coordination and collaboration for ICT improvements and commissioning new systems. So that's again to make sure we're always in the loop in relation to new systems coming out that is providing information that we need for, particularly for costing purposes. We're very good at putting data into systems. We're not very good at pulling it out on the far side in a manner that we need for costing. The plan's also about strengthening leadership understanding and supporting the workforce. So that's again about clarifying roles of responsibility and giving ABF a clinical focus with clinical leadership. And that's why I think Mike's role will be key as chair of the clinical advisory group, that becomes, if you like, the file around, I've mentioned best practice tariffs, or if there's other areas where we can use the funding or use the pricing process to incentivize clinical practice, then I think we should be looking at those issues. But again, that Mike will be the person who would decide on that. FAIRCA can obviously implement it in the pricing if required. We've also mentioned the plan covers a roadmap for structured purchasing, and that's, structured purchasing is a form of commissioning, I guess, and that's happening. It's happened already with the private hospital piece. That's certainly the first piece that I see. You could argue the best practice tariffs are a form of it, but really it's likely that we will have an engagement with private hospitals for the next few years. And I think pretty much our rolling out of the HSE payment platform for activity in private hospitals is acknowledging that fact that we're moving into a new space in relation to how we engage with the private hospitals. Purchasing, I mean, what it is. So the ask here really is that we research what's happening around the world in relation to the purchasing, and setting out a roadmap to design and implement the level of structured purchasing that emerges from the research. So that's work is actually taking place at present, but notwithstanding that, we have actually, as I said, we're started out in the procurement piece, the procurement framework for the acute hospitals. And the final piece then is just the scope and implement foundation costing for community costing and pricing program. So before you can think about bringing a community into ABF, you have to have costing. But to know the costing, you have to know what you're costing, and there has to be, that data. It has to be available data. It has to be collected in a similar manner, and we obviously, you have to have standards then around, how you collect the data and how you cost it. So that's certainly very much in the early stages. But the nursing home area is certainly one that has been flagged in Sláinte Care as part of the shift left. So again, we're able to compare the cost of a patient in an acute hospital bed. So we're probably up roughly about €1,000 per bed day is the average inpatient fully absorbed cost per bed day. I guess it's probably about €1,500 a week in a nursing home, and maybe 30, 40 euros an hour for home help. So I guess with the RHAs coming in and you're the budget holder for those three areas, it makes you think around what's most appropriate treatment for the patient, not just from a cost perspective, but also I guess from the patient perspective as well. So next steps, and I'm just conscious of time. So the next step really is for the hospitals, I guess, to develop hospital-level implementation plans, including for governance, workforce, and infrastructure. And I think, look, we will certainly be in contact with the hospitals and hospital groups post the conference to start the engagement process. So I think Stephen has mentioned as well that the kind of funding available is subject to the plans being in place, and indeed that the previous funding that was allocated for ABF has been used for those purposes. Support increased uniformity in coding and costing across hospitals and groups, and that's a given. And this is where I think the ask participate in pilots for outpatients and ED is required. So I think we've started that with the ED, and we have another 3 hospitals lined up. We've the initial piece with on the outpatients with Limerick. So again, we'll be looking for further hospitals there. So I think we have to we have to engage with the hospitals around that. If the hospitals don't provide us with the data, then we can't develop the classifications or the costing piece. Identification of legitimate and structural costs not accounted for within the ABF system, and that's goes back to, again, we've taken the word straight from Australia there. Sorry. Thanks, Jennifer. So we will be looking at developing a group to look at those issues that will be chaired by Mark O'Connor on the costing side. Ensuring appropriate resources for costing and coding, and that ABF then becomes part of the performance management process. So again, that's the proposal. The HPO will obviously provide assistance, and a lot have mentioned this already, around increased training, the costing improvement, the stakeholder engagement plan, and support with relevant ABF educational resources. I think one of the things we'd like to do, and I think it was mentioned by Mike, that ultimately you'd like to get ABF on the training agenda for training of doctors. So when you start, it's not just a handwriting issue, but that if it became part of the training or the what's the word? It's the whatever. Induction, whatever their training is, but so to try and go back to that, because obviously in a hospital they change after 6 months, and there's a lot of effort going in at the hospital level, but it's certainly one that we feel will be of help going forward. And I think that's all I have. Yeah. So I know we're coming up to lunchtime, but if there are any questions, I'm quite happy to take them.